my job here tonight is to talk a little bit about the framework in which the clinical care, and particularly the drugs and therapeutics that Patrick went through, are utilized for the cystic fibrosis community. And I think one of the reasons that CF is featured is because this is a pretty unique framework with a lot of robust tools to be able to determine by clinicians and patients, are we really using the right treatment at the right time for the right person? So it's anchored with the foundation itself. The mission of the Cystic Fibrosis Foundation, like many other patient groups, is to cure a disease, but also to provide the people with that disease, with cystic fibrosis, the opportunity to live full, rich, productive lives. And we do that in a variety of ways. We fund research and drug development, promote individualized treatment, and ensure access to high-quality specialty care. And as you'll note, that last part is highlighted because we think it's particularly relevant to what all of you do. Again, the foundation does have a pretty broad, a lot of different components in the way that we achieve that mission, ranging from community advocacy to a robust effort around drug discovery, development, and basic research. But what I really want to talk to you all tonight about is the clinical care portion that's highlighted in the lower, your right hand corner. Because it really is, again, a framework in which things are delivered. And in many ways, you can think of the cystic fibrosis clinical care approach for the foundation as a specialty medical society. So I want to walk through some of the tools in the arsenal of what we do to deliver that care. Patrick mentioned a couple of times that we have a network of national accredited cystic fibrosis care centers. The vast majority of these are at academic medical settings, and as you'll see, they're across the country. And the great thing is they're pretty much evenly divided between adults and pediatric programs because we have seen so much success in the care of cystic fibrosis. And last year was the first time that we had more adults than children in the CF community. So we need a bunch of adult programs, which is a great development in and of itself. The centers are, just to note, they are accredited through a peer review system. And actually in a meeting several years ago now with some of your colleagues, one of them said, "Do you ever kick anyone off the island and of the accredited network?" And the answer is, well, not frequently. Yes, we do. Accreditation is important, and there definitely is a benchmark standard for that. The care centers are important. As Patrick went through, there are a host of issues that come up in cystic fibrosis. And as Jim mentioned, it's a rare disease. So most pulmonologists aren't familiar with cystic fibrosis. It is important to have a specialty team. And as you see reflected here, the blue components of a CF care team are what are required for accreditation as a cystic fibrosis care center. And the green are recommended team members. One of the things of note that the foundation is working on a lot right now is to reinforce and assist care teams to add more of those green and yellow care team components so that the care really is multidisciplinary and robust. I'm going to show this slide twice tonight, and I think it's important because, as you'll see, what we think of as accreditation is there is a bar that you must meet in order to deliver high-quality, specialized care for cystic fibrosis, and accreditation is a part of that. That is the low end of a bell curve to say you must be at least here to be able to deliver good quality care. You heard a lot about the patient registry. It is a really key tool across the success story that is cystic fibrosis, across those gains in age and survival that we've seen. It's used in a variety of ways. It has been a very essential tool in drug discovery and development, in designing clinical trials that really target the right patients. As Patrick talked about, the introduction of a modulator approach meant that we had to get the right patients with the right genotype for each of these therapies. The registry was a really important tool for that. It does have a lot of strengths, and I actually think the Cystic Fibrosis Foundation's patient registry, if not the oldest, it's certainly one of the oldest patient registries around, and certainly also one of the most robust in the breadth of the population it collects data on. It's probably over 90% of the patient population in the United States, and also the depth of the data that we are able to pull out of it. But it does have its weaknesses. Some things that we think about are, can we really dive deep enough into some of the outcomes of some of the comorbidities that we're talking about? It is quite focused around some of the traditional pulmonary and GI issues around CF. So things like mental health would be places that we'd like to know more about and maximize the registry. Also for your purposes and also for mine, as I spend a lot of time thinking about managed care and payment models, we have weaknesses on demographics of things like insurance coverage and outcomes and how we can correlate those two things. It's been a really important tool, especially as a lot of these new therapies are coming on board. And Patrick pointed to some of the data, and a lot of that new methodology is going to be presented in our upcoming meeting at the end of the month for cystic fibrosis. But what's exciting also about the registry is that we can really utilize it to help correlate real-world data on some of these new therapies. And what we're seeing, it's exciting, especially for a drug like ivacaftor, is that it is correlating quite closely to the clinical trial data. As you probably know, a clinical trial is not the real world. It's a pretty finite, rarefied air. But what the registry is showing us is that a lot of the benefits, especially in these new therapeutic approaches, really are carrying forward into the general cystic fibrosis population. So it's been an important tool for us to really know that this is the right drug at the right time for the right person across the population. As I mentioned earlier, the registry is used for, and this is a slide you may want to pay attention to for that quiz later. The registry is used across the board for a lot of components of cystic fibrosis care. Again, it is utilized as a traditional model of natural history, disease surveillance. Again, I mentioned a framework for clinical trials. Post-marketing surveillance studies, it's something that's quite commonly used. Quality improvement, which I'm going to come back to, and importantly, comparative effectiveness research to really utilize evidence-based clinical decision making. So it's got a lot of assets and has, again, I think probably been one of the secret sauces in the success story of cystic fibrosis. Another really important tool that utilizes registry data is the foundation does provide clinical practice guidelines. You saw a snapshot of those in terms of highly recommend and on down the scale. They are by and large evidence-based, and when that's not possible, they are specialty consensus-based. But they're also a really important tool that is used across the network of CF care centers to determine what therapies are utilized. Another really important effort that has been around for probably a little more than 15 years in a really robust fashion is the notion of quality improvement across the network. This is a screenshot from a supplement to BMJ a couple of years ago that really categorized the effort of quality improvement in cystic fibrosis. And I think you see in the cover shot, we're proud of it because we think this quality improvement effort has really led to gains in survival for cystic fibrosis across the population, not just in pockets of real specialty centers. And this, going back to that bell curve, where if you think of it, it's how do we get everyone up to the top, up to higher quality of care and better outcomes for all people with CF. I see Patrick and I should travel together often because he showed you this one, but it's one of my very favorite slides. And I think it really does do a great job of telling the story of why the CF Care Center network and all the tool sets really have led to a really robust increase in outcome and survival for cystic fibrosis. And it's not just about the drugs. They're critically important, and we wouldn't be where we are without them, but it's also about the setting in which they're delivered and how we lift people up across the network, no matter where they get their care. So as you saw, this is a cross-section of centers. Those are the dots where we're looking at two critical components of cystic fibrosis outcomes: lung function, or FEV, and BMI. And you see how those dots moved from all around the axis, migrating where almost all of the care centers are up in that upper quartile where we want to see them over the course of time. I think that's an amazing story. I can never get enough of the scatter plot, because what it means is everyone is living longer. So I think that's a really important utilization of the quality improvement effort, because it means that it's translating down into across every patient. What's working? What have we learned from the guidelines? And how do we translate those best practices across all people with cystic fibrosis? And the bottom line is, what that means is people are living longer. Look at that median age survival. I don't get tired of looking at that. I want to talk also about the impact of these high-cost drugs and high-cost care that comes with specialty rare disease care. This is a summary side of some annual survey data that we ask of people with cystic fibrosis. How frequently are they delaying care due to cost concerns, and how frequently are they altering or skipping doses altogether due to cost concerns? In other words, their individual cost. Are they having co-pays, out-of-pockets, co-insurance? And as you see, it's not an insignificant portion of our population. About a quarter of them report routinely delaying or skipping care altogether because of cost concerns. And this is just another snapshot of that data by insurance type. The Medicare population, not surprisingly, with those with the donut hole, really does carry a heavy burden on this, but it does cut across many of our insurance types and is a significant concern, because when you're delaying or skipping your care, you are not benefiting from it. So what's next? If we have all these really great therapies and a really robust network in which to deliver them, but yet our patients are still not maximizing the benefit that we're seeing, including for reasons of cost. I think we want to emphasize that we in the CF community are asking questions that we know many of you are asking too. How do we really combine this notion and the challenges that come with high-cost specialty care into improved outcomes to deliver higher care? And where are we going? We want to make sure that we're measuring and understanding the efficacy, so we can really say robustly that we're delivering the right care at the right time for the right patient. This is just a snapshot of some of the things that we are working on as a community and with the foundation and many of our care centers. Points of care dashboards for both clinicians and patients and families. A care model of the future that's really embedding a lot of the value questions in there. We're examining bundled payments for cystic fibrosis. I think one of the main challenges, if you're interested in this thread, is what is an episode for cystic fibrosis for something this chronic disease? And certainly examining some new research opportunities, which Patrick touched on. We're doing a lot around the notion of partnering to support daily care. Think of another way, adherence. This is a very burdensome disease, and we know we really need to have robust supports for our community to make sure that they have what they need to adhere to the care regimen, and really embedding community input into all of this work. I wanted to throw out a few things building on the framework that you guys may think about, and some of the tools you utilize, and are they effective in cystic fibrosis? And sort of how I think of them is, do they coincide with that delaying and skipping care data that I showed you? Particularly with a network like this, what are the tools that you can utilize that work well to deliver the care and the prescription drugs that folks need in a timely and effective manner, and enable the care teams to really tackle the disease rather than some of the managerial requirements? So prior authorization processes, are they reasonable for providers? Can they look different when you know they're delivered in a specialty care setting? I think that's a particularly important question for the frequency of reauthorization. Do the requirements align with medical evidence? Are individuals who understand the needs of the people with a complex rare disease making those prescriptions? What tools can be developed to ensure understanding for those clinicians and also for your decision makers? Is the plan benefit design sufficiently flexible to enable the delivery of high quality care? And are things like auto exemptions and attestations list reflective of the current disease realities? So perhaps we could talk about that in the discussion. So the key takeaways: this care is delivered in a comprehensive multidisciplinary specialty care model. The community across the board has a lot of different tools and resources to help manage the disease and really move towards quality improvement and best practices, the network of care, the patient registry, the guidelines, and also that advancements in clinical care and a robust focus on the development of new treatments and therapies has really, as Patrick already spoke to, extended the lives for people with CF by decades.